This is a presentation on amniotic fluid embolism by Kavina Desai and Zach Stepp. So we'll start off by just defining what an amniotic fluid embolism is. You'll hear us referring to it also as AFE. So AFE is a rare life-threatening complication that can affect both the mother and the baby. The maternal mortality ratio associated with AFE has been reported between 0.5 and 1.7 deaths per 100,000 live births. Neonates have a high overall survival rate with greater than 90% of infants surviving. AFE is a serious reaction triggered by amniotic fluid or by other debris that enters the maternal circulation. Fetal material in the maternal circulation has the potential to trigger a massive cascade of inflammatory and hemostatic reactions that culminate into cardiopulmonary collapse and disseminated intravascular coagulation, also known as DIC. The case study that we describe later on in the presentation is the DIC type involving bleeding and the rapid deterioration of coagulopathy. Some patients may present with a combination of the two types. So the incidence of AFE is difficult to establish for a few different reasons. There isn't a universally accepted definition for identifying cases of AFE. So as you can see from this table, the diagnostic criteria slightly differs even from like the US compared to like the Society for Maternal Fetal Medicine, and it's different than the criteria used in the UK. So the lack of uniform diagnostic criteria, along with the fact that AFE ultimately gets diagnosed by exclusion, it adds a significant barrier to furthering our understanding of AFE. So the exact pathophysiology still remains unknown, and most of the data confirmed regarding the pathophysiology and the triggers associated have been from like autopsies and animal studies. The picture on the right does a good job of summarizing what's known regarding the pathophysiology of AFE. So an amniotic fluid embolism occurs when the amniotic fluid or the fetal material enters the mother's bloodstream. So it's not always just amniotic fluid, but also things like fetal cells, hair, meconium that can enter into the circulation. And a likely cause of this breakdown is in the breakdown of the placental barrier, such as from like trauma from the intense contractions. And so, as this breakdown happens, the immune system responds by releasing products that cause an inflammatory reaction, which activates the abnormal clotting in like the mom's lungs and the blood vessels, and that's what results in the DIC. So, as mentioned before, AFEs are rare, and it's likely that some of the amniotic fluid that commonly enters a mother's bloodstream during delivery without causing problems. So, it's not clear why some mothers, when the amniotic fluid does enter the system, why it causes the embolism and why in some it doesn't. So AFE most commonly occurs during labor and delivery or in the immediate postpartum. It's also been reported that it can occur up to 48 hours postpartum. And as far as the risk factors, some of the common risk factors associated with AFE include older maternal age, multiple gestations, early separation of the placenta from the uterus wall, tears in the uterus or the cervix, intense contractions during labor, eclampsia, or delivery via C-section. So, because of the non-reassuring fetal heart rate tracings that can complicate AFE in labor, C-sections may be a consequence rather than a cause of intrapartum AFE. There's also a strong association between cesarean birth and postpartum AFE that persists among these women. So for the case study, we have an article that we found which had a 39-year-old Gravida 2 Para 1. She has a history of fetal congenital heart anomaly and polyhydramnios. She's scheduled for an induction of delivery at 37 weeks gestation. She requested labor analgesia, so she had a spinal epidural block that was placed at the L3, L4 level. And because of the polyhydramnios, a pinhole amniotomy was performed at cervix dilation at 3 centimeters. No major complications were noted until fetal bradycardia of 80 to 90 beats per minute, which prompted the obstetric physician to go for a vacuum extraction delivery. 30 minutes after the vaginal delivery, a large amount of bleeding from the uterus was observed, and the OB physician suspected it as like a postpartum atony. At this point, the patient's blood pressure was 112/89, heart rate was 80 beats per minute with a blood loss of 2,800 mLs. Red blood cell transfusion began along with the placement of an intrauterine balloon, and within the next 30 minutes, the patient's blood pressure decreased to 72/43 with now a SpO2 reading of 86%. The patient was intubated and a central venous and radial artery catheter was placed. Pulmonary embolism was ruled out because the central venous pressure was 5. Treatment began based on a high suspicious diagnosis of AFE due to a sudden decrease in the plasma fibrinogen levels and uncontrolled bleeding from a needle hole. Low dose norepi infusion was started and an occlusion balloon was inserted into the descending aorta. Uterine artery embolism was performed along with continued transfusion of RBCs and fresh frozen plasma or FFP using a rapid infuser. And in spite all of these treatments, her bleeding still remained uncontrolled, and the OB team decided to perform a hysterectomy. From within 11 minutes from the start of surgery to hysterectomy, the hysterectomy was performed, and the fibrinogen levels increased above 100 milligrams per deciliter. Embolism of the uterine artery was also performed at and her bleeding was controlled. The blood pressure became stable without the norepi infusion, and then the patient was then transferred to the ICU. So just to summarize, to get a better picture of the blood loss and the blood products that were transfused, the total bleeding amount was 1,200 mLs. She received 38 units of RBCs, 36 units of FFP, and 60 units of platelets and fibrinogen. The patient was then later extubated on the second day after surgery. Post-op day 3, she was transferred out of the ICU, and then she was discharged home on post-op day 16. A month later, immunostaining examination revealed fetal components in the uterus, confirming a diagnosis of DIC type AFE. This case study shows early diagnosis and early intervention treatments can improve mortality rates in patients with AFE. The patient had a risk of AFE due to the advanced maternal age that we mentioned before. She was 39 years old. She had the history of polyhydramnios. She had the amniotomy, and she was inducted for delivery.
After discussing the pathophysiology and the case study of the mother with amniotic fluid embolism, we want to discuss some of the anesthesia implications. So for these patients experiencing amniotic fluid embolism, the care of us as the anesthesia provider is going to be very similar to any of our patients, just with a few different changes in our focus and expectations. So we're going to go back to basics and focus on the ABCs for this patient. We're going to make sure that we have all standard monitors that are required by the ASA that we use for each of our patients. We're going to ensure a safe and secure airway. We're going to notify any pertinent teams that need to be available for us to provide adequate care for this patient, whether that's the OB team, the NICU team if imminent delivery is expected, critical care team, the OB surgeon if a C-section is expected, which is probably likely in this case, especially if the mother starts to decline. And then we're going to treat hemodynamics and coagulopathies as needed, like we would with most of our patients. So then some additional anesthesia implications here. For patients that might be experiencing this event of amniotic fluid embolism, early recognition and quick aggressive resuscitation is vital for the survival of mother and baby. Diagnosing amniotic fluid embolism is kind of difficult. It's only by exclusion. So we need to make sure we have a list of other possible differential diagnoses to help us rule out other possible causes. However, if cardiovascular collapse is occurring, then amniotic fluid embolism should be assumed early on. Some of the changes that we're going to see on our monitors might include a rapidly decreasing oxygen saturation, or possibly a sudden decline or even loss of our end tidal CO2 waveform. One of the first signs of amniotic fluid embolism is usually fetal distress. From an anesthesia provider perspective, we're worried about both the mother and the baby in this case, and we'll again have teams of people available to us to help monitor the fetal status as well. So communication is going to be key throughout this case, because there's going to be so many people and so many teams in and out of the OR that we need to be relaying information to make sure that we're ensuring the best outcome for both mother and baby. If cardiovascular collapse does occur in the mother, the uterus should be displaced to the left for any resuscitation efforts that might be needed if the fetus is still in utero. However, if cardiovascular arrest does occur, C-section will be imminent, and some studies have shown that needs to happen within 5 minutes. If we're able to get a C-section started within 5 minutes, it improves outcomes for both mother and baby. Due to the rapid decline in cardiac and respiratory systems that can occur, frequent ABGs should be obtained to trend lab values, especially looking at hypoxemia, as low oxygen saturations and hypoxemia not only impact the mother, but also the baby and placental perfusion. Because expected coagulopathies happen with pregnancy in general, they also occur with amniotic fluid embolism and are sometimes exaggerated. So because of this, we should not only just expect to have coagulopathies, but be checking those coagulation labs and CBCs frequently. If necessary, we may also want to obtain an arterial or central line access to help make lab draws and fluid resuscitation easier. The foreign substances that live in the amniotic fluid can cause an anaphylactoid reaction in the mother, which can present as pulmonary hypertension and right-sided heart failure. If these things occur and get worse enough, alternative therapies may be considered for the mother. Those might include exchange transfusions, extracorporeal membrane oxygenation, cardiopulmonary bypass, right ventricular assist device, or possible uterine artery embolization. Again, communication here is key. We need to be able to anticipate what is needed and be prophylactic about treating our patient for possible hemodynamic changes that might be associated with any intervention that's required. For the pulmonary hypertension aspect, we may see inhaled nitric oxide to be included to help reduce the effects of that pulmonary hypertension. Some takeaways, and kind of summing everything up, we're going to go back to the ABCs. So first, airway. We want to make sure that the mother has adequate oxygenation, and that is a vital monitor in these patients is the SpO2. They may only require a nasal cannula. Maybe they won't require anything right away. Or if respiratory distress occurs, they may need to be intubated. B, for breathing. If the patient does go into respiratory distress and is unable to ventilate adequately, they'll need to be intubated, and extended ventilatory support will likely be required. And for C, circulation, hemodynamic stability is the goal of all of our interventions for this patient with amniotic fluid embolism, and we're going to obtain that goal through fluid resuscitation, vasopressors, inotropes, blood products, any of the interventions that we discussed in the last slide to help maintain that for mother and baby. And then, just to sum up a few other things, we're going to establish expected differential diagnoses to rule out other possible causes of what might be happening. We're going to at least make sure we have 2 large bore IVs. Um, Most likely, we're going to be wanting to have a central line and then get arterial lines in as well. And again, we need to expect coagulopathies in these patients. So some studies out there have supported the use of factor 7A to help with some of these coagulopathies, but it should be noted that there's a significantly higher risk of thrombus development with giving that medication. Again, we want to assess, monitor, and communicate. Those are going to be key for this patient and all of our patients. Ensure every team member is on the same page. Communicate vital signs and patient status to the team frequently and early. And if status begins to decline, make sure that you're not the only one in the room that knows, because it could have major impacts, not just for the mother, but for the fetus in this situation. And then here are our references.